Good afternoon, everybody. My name is Haley Yates. I'm the manager of strategic solutions here at UBA. And on behalf of United Benefit Advisors and Lucent Health, I welcome you to today's presentation in the UBA Employee Benefit Webinar series. Today, our topic is Ready to Move from Fully Insured to Self-Funded, presented by Mike Cavallo, VP of Reinsurance at Lucent. So with that, Mike, the floor is yours.
Excellent. Thank you, Haley. So as Haley said, this is the Ready to Move from Fully Insured to Self-Funded webinar. I myself, I like to consider myself a reformed broker. So I am familiar with what the UBA advisors, as well as some of the employers and HR staff are going to when considering this move from fully insured to self-funded. So going into it, the key takeaways we want to get out of this are to identify cost-saving opportunities available with self-funded plans. We're going to explore different kinds of plan designs and strategic tactics and risk management strategies to support your transition. And then understanding your requirements as a plan fiduciary, which if you offer a 401k, it's very similar to what you're doing today. So there's going to be a lot of similarities to that process as well. They're just adopting it into the employee benefits space. So this is a topic I'm very passionate about. Reason moving from a broker to the TPA side was to work a lot more with self-funded plans and placing reinsurance for Lucent Health. But to go into that, we have to understand where today's benefit landscape is. So if you are if you are in a fully insured plan today, I'm sure you know about the decisions around GLP-1s and seeing about the plan impact and the cost impact that has for offering these for employees who may be looking to lose weight. And then I'm also sure that if you're getting the data today, that you're seeing the impact on specialty medications. So a specialty medication, as I like to say, is any of the ones that you would see advertised on TV. They usually come with a pretty hefty price tag. And about 2% of the population is on a specialty medication, but it makes up for 56% of pharmacy spend. It can make for up to 56% of pharmacy spend on your costs today on your plan. So having a plan design moving from fully insured to self-funded and some of the risk management and mitigation strategies that we'll discuss will help, I don't want to say provide a silver bullet, but at least give a tactic to bend the curve essentially and buck the trend going forward. Also in today's landscape, a lot of people, there's a lot of comorbidities, as we call it, from the underwriting side, meaning that people, the populations have either one ongoing disease or, in the case of a comorbidity, two or more ongoing diseases. It could be diabetes and hypertension. It could be cancer along with another illness going on. So all of these are factors into driving up the cost of healthcare, which according to McKinsey can rise from approximately can go up about 9 to 10% through 2026. So moving forward into identifying self-funded tactics is understanding why employers choose self-funding. And really this comes down to transparency. We buy insurance unlike any other commodity we buy today. You can go out there and you can shop for a TV or a car. You can price everybody against each other, from the different vehicle makes to the different manufacturers within a TV. And you can know approximately within a couple of thousands of dollars or hundreds of dollars what you're going to spend. Well, that's not really the case with healthcare. A lot of people in older models go out there and use their PCP that their family has gone to forever, and they couldn't tell you if Dr. Jones or Dr. Smith is better from a cost and a quality standpoint. It's just someone that everybody in my family has gone to, and we continue to do that. Really, why employers decide to go self-funded is they're opening up their eyes to the transparency, and they want to get more control in their cost, in their benefits program moving forward. So from a control standpoint, if you are fully insured right now, especially with plan design, you are subject to ERISA. You have to take the federally mandated benefits, but you also have to take the state mandated benefits. So one of the benefits that you can get from going self-funded is you still have to keep the federal mandates, but you could choose to elect the state mandates or not. So in Connecticut, where I am located, there is a benefit for autism that's above the ACA regulated mandate on how to treat that disease. So what we could do in a self-funded environment is decide to adopt the ACA minimum, or we can take the state guided benefit as well. But that choice is up to you, the employer, versus having it being dictated to you. You can also customize your plans. A lot of TPAs, like Lucent Health, will allow fully customizable benefits down to prescription drugs, ER copays, PCP copays, inpatient hospital. You really get to put your touch based on what your population is like when going self-funded. You're also getting transparency. And this to me is the biggest one here is, as I said earlier, we buy insurance unlike any other commodity we buy. You're getting access to your data. And your data is in fact your data. And there is now a law called the Consolidated Appropriations Act, which I'll touch on later, that states that you as the client have access to this data and you cannot be denied it. So because of that, with the transparency aspect, you are in the driver's seat here to see what is going on with your population at a high level. And I know for the HR team, you can go as granular or as high level, so you're not getting into PHI and HIPAA. But you have access to this claims data where if you're on the smaller side, fully insured, you may not have access to this. You could also see the impact of pharmacy and specialty cost. And then you could also provide that protection so that you're not going into this completely blind through stop loss, where all of this is actually built into your plan, which I'll get to in a minute in terms of how it's structured. But you can really pick and choose, can I put the best of the best from a pharmacy claims manager, a pharmacy benefit manager to the network I need, to the plan design that fits my population, all while doing it transparently. And on top of that, there's bonus savings for it. So the average savings when employers move from fully insured to self-funded is approximately 20%. So how can a self-funded plan reduce costs for employers? Well, right now, under fully insured, you're hitting an easy button. You're paying a monthly premium, and included in that monthly premium, it will have everything that you need to pay the claims, administer the plan, pick your pharmacy benefit manager, and then you'll pay taxes on that. Included in that premium is also profit that the carrier builds in. And with the taxes, what's interesting on this piece is that taxes are paid on 100% of the premium. So when we talk about ways to reduce costs for employers, you're paying the state tax. So let's say it's 4% for the state that you're in. You're paying it on 100% of the premium that you're paying to the carrier today. Really, when you go to self-funded, you're only paying that tax on a smaller portion of it, which is the stop loss premium, and it's done on a much lower amount. So what happens here is when you take it out and you unbundle it, so what I like to say is you will unbundle to rebundle, so you disassemble to reassemble your plan, you're going to have the same components that are made up in a fully insured plan, except it's going to have your input into how you want to do it. So to give you an idea of the costs associated typically with a plan, I've broken it out into approximately how much each block here represents in terms of that premium you pay. So for claims payments, depending on the size, it could be from 60 to 80% of your spend. For the stop loss premiums or pooling charges, as it's called in the fully insured world, it could be 10 to 30%. For the admin fees, this is one of the smaller portions of it. It could be about 3 to 5%. And then the pharmacy rebates, which if you know what a pharmacy rebate is, it's a coupon, as I'll refer to it, or a give back in terms of dollar amounts that pharmacy benefit managers will use to incentivize you to take that medication. That can actually be worth anywhere from 5 to 10% of your drug spend. So now when you go from fully insured to self-funded, you can actually have the transparency, as I mentioned, into how much your claim spend is, what you're paying for stop loss premium, how much your admin is, and these pharmacy rebates that are coming back to you. So the total sum of your self-funded plan is very similar to what's fully insured, except now you have insight into it and you have control into it. So where does this come into if you're breaking it out and saying, all right, Mike, I understand all of this, and I could see that each component is worth something. Well, where does the savings come into? Well, fully insured, I'll equate it as to you are buying an entire grocery store, whether you need it or all of the groceries in there or not. You have to take what the state and the federal mandates, the legislation mandates, and then you also have those pharmacy rebates I mentioned. Those are like those coupons. So in the fully insured world, it's like you're going grocery shopping, you're buying everything in the store, and the store is keeping your coupons on top of it. When you go self-funded, it's like you're shopping off a grocery list. So you can only pay for what you need from the services you get, but you also get to use your coupons. And when you use those coupons and paying for the services that you need versus being mandated to take everything, you're going to create potential savings there. What also happens when you go from fully insured to self-funded from a cash flow standpoint is you're paying for 12 months of claims, whether they're happening or not. I'm not sure if everybody here is familiar with an HSA plan, but the concept is very similar on an HSA compared to like a PPO plan. A PPO plan, you're paying for services that you may or may not need at a higher premium. On an HSA plan, you're paying as you go. The concept works very similarly with on a greater scale from a cash flow standpoint. So under fully insured, you're paying those 12 months of premiums regardless of how the claims happen. What happens when you go to self-funded is that there's a lag. So the lag happens that when you switch over, any claims that are incurred under the fully insured contract remain there. So what ends up happening is you end up spending in your first year approximately 10 and a half months of claims, 10 to 10 and a half months of claims versus the full 12 months of claims. So you're essentially paying as you go once the claims come in from a cash flow standpoint, where you don't have to budget. You can set the budget accordingly, but you don't have to have necessarily all 12 months of cash on hand right away. So you do have a better cash flow, and you are paying for this from a timing standpoint as the claims happen versus prepaying for everything and then not getting any of those refunds back unless you run significantly well, in which case you'll only get a portion of that back. So how does this impact your risk? So one of the biggest reasons employers are scared to make the leap from fully insured to self-funded is that there's the concept that one, it may be too hard to administer, or two, it's going to be too risky for me to do so. And when evaluating the risk, and this is where your partners at UBA can come in to help, you want to make sure that you're striking a balance. On the left-hand side, I've got a beautiful picture of a beach, and I'll call this the destination plan. What you want to actually go against is being the destination plan. Because now that you are self-funded, you're taking on the risk. You're not paying for that margin, which can be upwards of 4 to 8% in your fully insured premium. You're not paying for that margin or that risk charge that the carriers are tacking on. You are now the fiduciary, and you are now the one taking on the risk. So if you offer a plan that's too generous, what's going to happen is you're going to attract everybody onto your plan. And what happens when you attract everybody over to this beautiful beach? You are inviting risk onto it. And that's what you want to make sure that you're limiting. You want to be, you can absolutely offer a very competitive plan with great contributions. But if you are too rich, you're going to be everybody's favorite choice. And that means you're attracting more risk. On the right-hand side here is if you're too lean, you're going to invite something what's called adverse selection. Meaning if you are really going down to a bare bones plan design and you are really going down to a lower contribution amount, the only risk you're going to end up attracting is the sick risk, and you're not going to be able to balance it out with any of your good risk. So really what you want to do is strike something in the middle where you offer a competitive plan that will bring stability for not just your current year, but future renewals going as well, and pair the plan design with appropriate contributions to make sure that you are attracting, good risk as well as bad risk. Because honestly, you won't even know if you have good risk or bad risk in there. What you want to do is put the guardrails up to make sure that you're striking a balance going forward. So how can employers mitigate risk? And we're going to talk about a couple of concepts here. So we're going to cap the high cost claimants with strategic stop loss. So that is my job at Lucent Health, is to evaluate the stop loss contracts or the pooling levels that we'll set for each belly button on your plan. To give you an idea, a 100 life group may elect to purchase stop loss insurance at about $50,000. Okay, and that's $50,000 per member covered on that plan. So essentially, you would self-insure up until that $50,000 threshold, and then anything over that $50,000 threshold would be reinsured by the stop loss carrier, and you would pay a premium to do so. Going back to the previous slide, it would be about 10 to 30% of your spend. You're also looking for cost containment measures and using analytics to drive the claims once you are getting that information. So plan designs and cost containment vehicles could be incentivizing carve-outs on outpatient surgeries. There are firms out there that will incentivize you to say, hey, listen, you want to put together a $0 deductible on this service or a $0 copay on this service, and we will migrate you over to an area that has high cost and high quality procedures for a shoulder surgery, a hip surgery, a knee surgery. This is where the transparency and getting access to purchasing and getting insight into models with claims is unique, where under a fully insured model, you're paying that monthly premium. Now that it's your risk, you're getting that insight and that transparency going forward. So you want to partner with both pharmacy strategies and TPAs to help build a cost containment program and give you access to a network that is going to fit your needs going forward. So all of these are levers that you can pull within a self-funded program, and we're going to compare it to how do you structure it compared to what you have to today. So under fully insured, this slide will look familiar. You have everything bundled in that nice package, but all of it comes with what the carrier is dictating to you. So you have that fully insured premium, you have that carrier administering your network, or administering your plan, providing their network, using their reinsurer and their PBM of choice or pharmacy benefit manager that they may own. And they are keeping those rebates, they are tacking on the profit, and you are paying a tax on 100% of the premium, all within that one carrier structure. Now, self-funded, this is your opportunity to get the best of the best. So you can select a TPA that offers a network that would work for you and your population. It doesn't have to be tied to a particular carrier, as long as that TPA offers that network and they're allowed to rent it. You can choose the reinsurer. All reinsurers are not created equal. You would want a reinsurer that has really strong paper, meaning that they are financially viable in order to reimburse the claims as they are coming in. But you can select not only the reinsurer, but the threshold in which you want to administer your plan. So at 100 enrolled employer, I had used the analogy of, or the example of a $50,000 individual stop loss threshold. You can choose to go to 75. You can choose to go to 25. Under a fully insured environment, that would be dictated and filed with the state. So you would have more control and insight and transparency into how much you want to take on from a risk standpoint for the reinsurer. The admin piece would go hand in hand with the claims payment, where you're selecting a TPA or a third-party administrator, such as like a Lucent Health, out there to offer a network that would fit for your population wherever they are located. And the key one here is, on top of it, is selecting a pharmacy benefit manager. You could use the likes of the big three. Optum, ESI, or CVS, or you can go to more of a transparent model like a Smith RX or a Lucent Health or another TPA, Livinity out there, where they have transparent pass-through PBMs. The point being on this is you get to be the architect and the designer of your self-funded plan versus being dictated to what you have to use in the fully insured world. So from the plan design considerations, now that we've selected, we'll fast forward and say, all right, we've selected our TPA partner. We are looking at our stop loss carrier and adjusting our risk tolerance accordingly. We want to make sure that we are customizing the plans very similar to my Aruba versus my, we'll call it Waterbury, where I'm from slide, where if it's too rich, you're going to attract a lot of risk, and it's too lean, you're going to attract just bad risk. So this is where the customization of the plan design structure comes in, where you really want to work with your team at UBA to make sure that you are structuring something that covers your entire population. You may have a mix of, from a generational standpoint, baby boomers down to Gen Zers, and you want to make sure that your plan design strategy would be something that accommodates all of the forms of employees that you have at your company. You also want to look at your network strategy. So you could offer a traditional PPO strategy where there's a network and there are providers that are providing their services at a discount. Or you could go into something called a reference-based pricing model where it's paying off a percentage of Medicare. Now, this would drive higher savings in accordance with your plan, but it also would provide some level of a little bit more disruption, as I would call it, or a little bit more noise for your employees as they are paying a percentage of Medicare, and there can be a negotiation going on in the back end, which is why it's important to select a TPA partner and a partner in the reference-based pricing space that will work with you and your population to reduce that noise. You also want to find that transparent PBM as part of the CAA, which I'll go into in a moment. We are going to have those, we are going to have the transparency be at the forefront of everything. There's a law in place today to make sure that you are acting within the best interest of your employees, and you're not taking those pharmacy rebates that you would get back as an employer and going out and buying a car or something for personal use. You want to make sure you're investing those back into your health program. So really, the cost containment aspect of this with the selection of the pharmacy benefit managers, your strategy around what kind of network, and your strategy along what kind of copay or plan design that you're going to offer really helps drive that savings outside of that initial lag that you get when switching from self-funded to from fully insured to self-funded. So these are some examples of the network strategy where you have in a traditional PPO versus a reference-based pricing model versus a hybrid model where you can have access to physicians under a PPO contract and then have the reference-based pricing or paying that percentage of Medicare for the facility aspect. But here, going through and choosing the right network strategy, reference-based pricing traditionally has been really good in rural areas where there may be one major provider, and they are charging exorbitant amount of money for services because there is no competition. So that's where the reference-based pricing model initially came in, and then it's been adopted. It's been adopted across the country in different areas because they saw the viability of it, and they also saw the savings associated with it. You can get savings as high as 40% on facility claims, but there, as I mentioned, there could be some disruption that you would have to manage. Under a reference-based pricing model, there is also the chance of balance billing. So that's where you want to select a TPA and a partner there to manage that reference-based pricing to make sure that there's not a full amount of disruption and balance billing going on for your members. So understanding stop loss insurance, there's two levels of this when designing your program. So the specific stop loss is for individuals, and that's per belly button. That's at $50,000 of insurance I mentioned for a 100 life employer. But there's also something called aggregate stop loss insurance that you would buy to go along with it, and that covers the total amount. So instead of looking at each individual at $50,000 for 100 life group, to do simple math, you could buy aggregate stop loss in the case of a really, really bad claims year. So that threshold is basically saying I'm going to buy aggregate stop loss if I expect $1 million in spend is my expected, I'm going to protect myself up to $1.25 million. That's at 25% threshold. If all of my claims that are underneath my individual stop loss threshold exceed 1.25 million, all of that is going to be reinsured back to me, and that is the most I would pay during a plan year. So the stop loss when looking at risk is twofold. One, you want to make sure that you have the adequate individual risk based on your size and your cash flow and how much liquid cash you have on hand to pay claims. And then the second is the aggregate stop loss as to what the maximum you would be able to pay in the essence of a bad claim share, which, as I mentioned, typically has a 25% threshold. So in summation with to manage your transition from fully insured to self-funded, a couple key pieces here. Making sure that you're working with your UBA advisor to have the right TPA, the right PBM, and having that open dialogue about risk. Whether you want to be on the beach side with having a better plan with better contributions and understanding the risks that come along with that, or being on the other side where you can put this to where you're gonna save money, but maybe you don't want to invest as much into it, and knowing that the risk that comes along with that adverse selection, where you may only attract negative or sick people. Really, the magic happens when you can find the balance between the plan design based on your population and the contributions that you want to set as to who you're going to get onto your plan. You also want to make sure that you are looking from a compliance standpoint, which I will transition into in my next 15 minutes here or so left, talking about being a fiduciary and what that means. So you want to be in compliance when you're doing this, and you want to train the HR and benefits staff as well about the new plan. One of the biggest misconceptions is that it's more work from moving from fully insured to self-funded, which could not be further from true. Once you establish your plan design, your network on the upfront aspect, and that's where you would work with your advisor to do so, it works just like any other plan. The frequency in which you may have to pay the bills would be a little bit different, but you're still going to have total insight into your plan, which that transparency aspect cannot be underestimated. Every person, the biggest question I used to get is, what does the ID card look like? Well, your ID card would have the network, the PBM, all of the information on who you needed to call, everything still on the back of that, ID card. It would just be with the different components that you chose versus having one carrier that would have everything. So it's still very similar from a process, as they would go to the doctor, show the card, and everything would be processed accordingly, just like you would fully insured. And then the other thing, obviously, is the communication aspect with your employees, and that's up to you as a plan sponsor as to letting the employees know, if you wanted to, if you went from fully insured to self-funded, knowing that you are now taking on the risk and that we are putting cost containment and transparency into this plan at a greater level to ensure that and communicate that we're all in this together. So you could choose to do it that way, because honestly, the employees wouldn't know unless you told them if you were fully insured or self-funded. They typically just know what their premiums are paying. They look to see what their payroll deduction is, and if there are any carrier changes. So the fiduciary aspect of this is not a new concept, but it's important as it pertains to going self-funded. So now once you go self-funded, you are considered the fiduciary of the plan, just like you would be under your 401k. And the responsibility of a fiduciary is to make sure that you're acting within the best interest of your party, meaning that all of the employees under the plan, you are not taking those rebates for personal use to go buy a car, a house, a vacation. You are taking those rebates and investing them back into the plan. And to make sure that all of the decisions that you are making within a plan is in the benefit of the employees. Because if you do not do so, there are penalties to be associated or that could be lobbied against you for failure to do so. So, what are your responsibilities as a plan fiduciary? So that's the items listed here. So, duty of loyalty, duty of prudence, duty of following plan documents, duty to diversify plan aspects or assets, excuse me, which is not putting all your eggs in one basket, duty to monitor and oversee delegated functions, and duty to avoid conflicts of interest. So, the old Elliot Spitzer situation with the conflict of interest and bid rigging. What you were trying to do, and to break this down as simply as possible, I've said it before and I'll say it again, which is you want to act within the best interest of your members. So everything that you are doing, you want to make sure you document it as it states here. You want to make sure that you are selecting benefits in the way that is appropriate for your population, and you're making sound judgments with the allocation of increases, which you would work with your UBA partners to do, and make sure that you're not overcharging for any of the services or any of the premiums that are being provided, and you are monitoring and continuing to update this on an annual basis.
Hey, Mike, we did get a question.
Excellent.
The plan fiduciary is the employer group, correct?
That is correct.
Thank you.
That is correct. Is the employer group. Right. So you are the fiduciary because you are the plan sponsor. You are selecting all of the components for the plan. And then you want to make sure that you have a plan in place to monitor and document everything that you have going on. So you, as they say, is the fiduciary, is the big F fiduciary, where you have to be responsible for everybody on your plan, just like you would be under the 401k side. And there are vendors out there. Innovu is one of them. Fiduciary in a Box is another solution that can help employers on what their fiduciary duties are in more detail than I'm doing on this presentation. But they're there to help as well. So there are other avenues for you to understand about all of the nuances with being a fiduciary.
Perfect. Thank you.
So the Consolidated Appropriations Act is new under 2020 as of 2021, and there are certain reporting requirements, such as the RxDC reporting that you would have to do to CMS annually. The biggest thing on this is gag clauses, or I should say one of the bigger things is the gag clauses on here that restrict access to quality or cost. Basically, you need to know where all of the hidden traps could be, or where in most cases, this applies to a lot with pharmacy benefit managers, where the definition of a brand name is, where they can trip you up and not pay a claim. Really, this Consolidated Appropriations Act is the vehicle for transparency. This is the law that was enacted in 2021 to make sure that employers have insight into not only the plan as it pertains to their own spend, but where the carriers and PBMs and all of the other components of a plan can make money and trip you up from a language standpoint, or basically get you into a gotcha moment where maybe they deny a claim because of how it's put out there. They're also responsible under the CAA for any kind of provider compensation disclosure for your broker, and it just has to be reasonable. So all brokers now have to disclose what kind of compensation they are making on the plan as well. And there also has to be mental health parity and making sure people have adequate access to mental health programs out there as well. So how can you limit your liability as a plan fiduciary? The steps here give a good outline that you would take when you move from fully insured to self-funded, which is you want to establish a fiduciary committee for the health plan that's responsible for the oversight and making sure you're not misappropriating any funds. You could purchase a fidelity bond, which is required by ERISA, which basically means that this fidelity bond that you would purchase is to make sure that no employees under your plan are acting negligently and falsifying information. You could also purchase fiduciary liability insurance, create a committee or a charter that sets out the duties and responsibilities of the fiduciaries and the committees. And then you want to have regular meetings and document what you are doing throughout the year and making sure that employees have access to that so they can also understand that you as the fiduciary are doing and acting in the best interests of the plan. And then you can hire, as I mentioned before, hire service providers to handle fiduciary functions and delegate responsibility. That's that Innovu or fiduciary in a box I had mentioned. But you could also work with your UBA advisor to see if there are any additional solutions other than what I've outlined here as well. And then finally, within wrapping this up, the key points I would say across all of this to get out of it is, number one, the control and transparency piece of this is to not be underestimated. You will have insight into information, whether you like it or not. When you make this transition, you will have insight into this that will only equip you for more sustainability as costs continue to rise. We know healthcare, as I mentioned, is something that's purchased very differently than anything else. And having the ability to have that control and transparency into your plan will help you build a sustainable benefit plan and a competitive benefit plan moving forward. The savings associated with it can be through just the initial change, where you would only pay 10 to 10 and a half months of claims in the first year, but also putting in those cost containment aspects. There are hundreds of point solutions within Lucent Health specifically where employers are trying different things to mitigate cost. We know that trend is something that you can't eliminate, but you can try to buck the curve. And that's really where those cost containment solutions come in. And then finally, with the fiduciary aspect of it, just doing things with the best interests of your employees in mind will help you going forward. The one thing I say I used to really like about the fully insured to self-funded conversion is that your renewals are unlike anything you would experience on the fully insured side, where you would have your UBA advisor or your broker go out and say, can you go out to market and get me the best quote? And then 10 or 15 best and finals later, you go from a 40 to a 5%. Right now, the transparency that you would have and the good folks at UBA can help predict those costs for you and give you projections where the renewal process becomes less strenuous and you can actually get out ahead of it a lot earlier. So hopefully you all found this helpful. I'm going to turn it over to the UBA team here in a moment, and thank you for having me today.
Thanks, Mike. I will leave the Q&A open. I know it takes a couple extra seconds to physically type a question, so if there are any questions, feel free to get those in here now. But I do want to thank you, Mike, for your thought leadership and sharing your expertise, and thank all of the UBA partner firm employees and any clients who joined us today. Our next webinar in the series will be on August 19th with Benecon, so we look forward to you joining us then. So again, thank you for attending our UBA Employee Benefit Webinar series. I hope you have a great rest of your day.